All right, so tonight we are going over head and spine injuries. I know I was getting kind of out of my lane a little bit yesterday when we were talking about the head and neck, and I was going into head injuries a little bit, but I kept saying that we were going to get to it when we got to TBIs. That will be tonight. So this is one of those lectures, even though it's trauma related, that we're going to be dealing with things under the skin again. So I want you to kind of think about this from a medical point of view, even though we're dealing with it as trauma. All right, so the first thing we're going to do is we're going to go ahead and go pretty much right into the anatomy review. These first couple of slides for the introduction just tell you what's included in your nervous system. So you have your brain and your spinal cord, which is your central nervous system, and then your several billion nerve fibers. Those are your peripheral nervous system. The brain, or sorry, let me rephrase that. The central nervous system does not have nerves. There are no nerves in the central nervous system. That is just your brain and your spinal cord. So no matter where you find a nerve, even if it's in the head, it's still considered peripheral. So your optic nerve, which runs from your eyes to the occipital region of your brain, which is actually at the back of your head, that's peripheral. It's a nerve. The vagus nerve, which we're going to talk a bit about tonight, because it controls so much stuff, that is your peripheral. So I don't want you to think that your peripheral is just the nerves that go to your fingertips. There is a little bit more to it than that, and we'll get to it. But just keep in mind, like I said, your central nervous system is your brain and your spinal cord. Those two things only. Your peripheral nervous system is everything else. All right. So for your anatomy review, your nervous system is divided into two anatomic parts. You have your central and your peripheral. Those are the two physical differences. All right. We have two like job description differences as well, as far as when we talk about the sympathetic or the parasympathetic nervous system. Those two systems are ways that the nervous system will function, but physically, it's the central and the peripheral. So if you start seeing those two terms or those four terms congregated together, they're apples and oranges. Central and peripheral refer to the actual structures, and then sympathetic and parasympathetic refer to what they're doing, which systems are taking control of the brain. Your parasympathetic and your sympathetic both exist in the brain. They're two functions of the brain, if that helps with that any. So here's a picture of your CNS. Actually, it's more than that. This is your entire nervous system, just kind of really dumbed down to one pathway. So you have your brain and your spinal cord is your central nervous system, and they're the ones that pretty much tell the body what to do. In fact, you can kind of look at it like the body's sole purpose is to carry your brain around. Everything that we do is controlled by the brain. If the brain wants something to be a certain way, it will make it that way, which is fine when things are working well. Somebody gets hit in the head in a bad car wreck or they fall, that kind of thing, then suddenly your brain may not be making the best decisions for you, and we'll talk about that tonight. So your brain is divided into three major areas. You have your cerebrum, your cerebellum, and your brain stem. Now, each of these is more critical in the order that I named them. So your cerebrum is the bulk of your brain. When you picture a brain, most of your brain is the cerebrum, and it's divided into two hemispheres. You have your left side and your right side, and that controls balance and body movements. So as you can see here in the picture, most all of this stuff, the parietal lobe, the occipital lobe, all that, the frontal lobe, that is your cerebrum. Okay, and then if you look kind of down at the bottom on the back of the head, you see that weird walnut, well, bigger than a walnut, but that one section kind of looks like a flower, I guess is the best way to put it. That's your cerebellum. That controls more body processes and a couple other things that are a little bit more critical than what the cerebrum controls. And then your brainstem, which is that funky yellow shape that runs down to your spinal cord, that controls almost all of your actual life functions. So your ability to breathe, your temperature regulation, your blood pressure, your heartbeat, all of that stuff is coming from that. And there's another spot, but we're not going to get into it. It's kind of hidden. You actually have to take the brain out and split it in half to see that fourth lobe, but it's there. It's just not we won't go that deep into it. So your cerebellum controls your balance and body movements. Your cerebrum, like I said, which was most of your brain, a lot of that is your memories, your cognitive thinking, as far as like higher levels of critical thinking come from that. There's one area that sits right about where your left temple is at. It's in the cerebrum, and it's your ability. They call it the Broca's region. And I only tell you this because if you're dealing with patients that have a stroke and they're having a hard time either speaking the right words or understanding the right words, that's pretty much where your problem is going to be. That's one section of the brain that's on the left-hand side, and it's right behind that left eye, kind of in that temple range. It's called the Broca's region, and that's where we actually have our language comprehension, both speaking and understanding. Oops, sorry. All right, so we talked about the cerebrum. Your cerebellum, like I said, coordinates balance and body movements, and your brain stem, which is at the bottom of your skull, is not actually, when you think of your brain, it's not actually part of that whole picture. This is what the brain connects to. It eventually becomes the spinal cord once it leaves the skull. That controls most of your functions necessary for life. It's also the best protected part of your central nervous system. But depending on what kind of accident you get into and what happens with in regards to a traumatic brain injury, that could also be the most critical, like most likely to get hurt. Because if you were to herniate, like we talked about the other night, where your brain contents and everything start to get shoved out of that foramen magnum at the base of the skull and into the neck, your brain stem is what's going to be getting shoved through the hole. One of the things that we have found through science and just cutting people up and all that stuff over the years is that the what we consider consciousness, not getting into souls and stuff like that, but just your ability to be awake and aware, is in your brainstem. We call it the reticular activating system, or RAS for short. You may see it abbreviated as that. That is in your brainstem, and if anything ever happens to it, your lights are getting turned off on you. Somebody shut the power off to your body, and you're pretty much a vegetable at that point. People that go into comas usually are there because they took damage to that section of their brainstem. Sometimes when we knock people out, if we give you a not really a tranquilizer, but if we give you something that's just going to completely knock you out, say like an anesthesia of some sort, a lot of times what that does is it goes in and it numbs out your RAS and it knocks you out that way. And as long as it's floating around in your system, your RAS is not able to function properly, and you'll stay in that completely turned off stage until it clears out. But again, if there's a brain herniation that happens, if you're dealing with a patient that's hit their head and they're unconscious, if they weren't unconscious before and then they went unconscious, that's a big sign that their RAS is affected, which could tell you that they may be about to herniate, because that means that portion is getting shoved down into the foramen magnum, which is that's the main hole at the base of the skull where the neck plugs in, and it's your cord, your spinal cord, and everything runs through it. For your spinal cord itself, this is made up mostly of fibers that extend from the brain's nerve cells. They go all the way let me take that back. They go almost all the way down your spine. Your spinal cord doesn't actually go to your tailbone. It stops a couple vertebrae up in your lumbar spine, and then it goes from there. That's when it branches off into your other nerves, including like your sciatic nerve, your femoral nerves, and all those. They run the rest of the way down your spine all the way to your tailbone, and then they span out from there. The cord carries messages between the brain and the body via gray matter and white matter of the spinal cord. And all you need to know is that those two things exist. I'm not going to get into the physiology of why we call it gray or white matter, but let's just say that if you were to actually look at it under a microscope, it would be either gray or white. And it's because of what's on it. Gray matter, for you guys, if you're curious, your white matter is mostly fiber pathways. Your gray matter is just the bodies themselves. It's the general bulk of your brain, or your spinal cord would be gray matter. And then you have pathways basically for faster communication. That's your white matter. The protective coverings, your cells of your brain and your spinal cord are easily injured. We do have some protection for that, though. You have your skull, obviously, your spinal column, and then even then, because the bones are rigid, we have on the inside where the nerves are and where the brain sits, we have a cushioning that's built on the inside of the skull, and we're going to learn the 3 different layers that make that up. All right. So your thick bony structures of the skull and spinal canal withstand injury very well. That's what absorbs most of the damage that comes to us from the outside, unless it is overpowering and breaks the bones. But then when you think about how inertia works and things of that sort, just because the bone absorbed the hit, if you move, you have that potential for the brain to hit the skull right on the inside. So we have what's called meninges on the inside of the bones, and this is in your brain cavity as well as your spinal cord, and that's just a cushion. It's like a really thin pillow, I guess you could say. It's all the way around, and your brain sits in a padded room. Then it is broken into 3 layers. So you have your dura mater, your arachnoid layer, and your pia mater. See if that's on here. Yep. Okay. So if you look where it says on the side, your outer layer is your dura mater. So what I want you to think about, the outermost layer of your protection is your bone, right? That's the hardest impact absorbing material that we got. There's nothing harder for us to protect ourselves with than bone. So as we get closer to the brain, the layer is going to get softer, thinner, more velvety, if you want to say that. Actually, it is kind of velvety. But each layer that we go in from the bone, the layer gets softer. So the dura mater, think durable. The dura mater is your outer layer. That's closer to the bone. It's a tougher material. It's designed to help absorb some of that shock. Um, then we have your arachnoid layer, or your arachnoid matter, and then your pia mater. What I always thought, actually, the way it was described to me in the PHTLS class one day, was that your pia mater, if you think of the pious, if you've ever heard that term, or piety, um, your clergy, your church, they say you're a man of the cloth or whatever. So they're not wearing armor. They're just wearing their church robes or whatever. The pious believers are usually just wearing regular cloth clothes, and that's it. And there's no real protection to it. It's just a covering. So your pia mater is the innermost layer. Your arachnoid layer, the reason it's called that is because if you look at a cross section of it, it looks like a spider web. That's your middle layer. So it's bone, dura mater, arachnoid layer, pia mater, brain. And then your blood vessels are going to run through that layer in each of those layers. And there's also going to be blood vessels in your brain. Let me ask you this. For those of you now, I got 12 people on now. So you're going to have arteries and veins going through your skull because you got to get blood to the brain and then blood back from the brain. If the closer we get to the brain and into the brain, actually, because you're going to have vessels inside the brain, we're really worried about everything being as smooth as possible around the brain. Which vessels do you think are in the brain versus which ones do you think run along the outside, kind of closer to the skull? If you think about what arteries and veins do. So in other words, like, all right, so arteries and veins, which one do you think is inside the brain? Do you think the veins are inside the brain or around or closer to the brain, or do you think the arteries are closer and inside the brain? The veins. Good job, Wesley. Yeah, the veins are inside the brain and around the brain. They're more tightly, they're closer to it. And a way that I always remember that is because we don't want to do very much change. We don't want to introduce a whole lot of pulsing, a whole lot of moving in the brain. We want the more durable arteries that are designed to move, designed to pulse, all that stuff. We want those a little bit closer to the bone, a little bit away from the brain. And the reason that I asked that is going to be very important. Remember that when we start talking about how people react when they get hit in the head, especially when we deal with hemorrhaging in the skull. because depending on which of those vessels popped can tell us a couple things, not just as far as like how much of a threat is it to their brain, but also how are their symptoms presenting. So if you get a patient that got knocked out immediately and they have extreme pain, um, that's going to tell you that they're having a bleed of one sort. If they have something that's been kind of going on for a couple of days and there's no pain involved, they're not hurting, they don't have headaches, they just have been not quite in their right mind, been a little sluggish, kind of losing their balance a little bit. Now they're having a hard time talking, but that's it. Um, those medical mysteries typically wind up being a different type of brain bleed. So we'll get into that more, but I just wanted to kind of bring that up now since we're talking about blood vessels in those layers. All right, so as you can see, um, this just shows you what I was saying. So you have your skin and your muscle, then your bone, that's going to be your skull. Then you have your Dura Mater, which is that very fibrous. It's not real thick. It's very fibrous. It's hard. It's almost more cartilagenic. So it's kind of hard like your ear. I would say it feel kind of like your ear, maybe your nose. Your arachnoid layer is the thicker layer. That's got a lot of air pockets in it. Those connections kind of look like spider webs, so they call it the arachnoid layer. Then we have your pia mater, which is the lowest level. Um, and then your cerebrospinal fluid just kind of fills in the gaps and maintains the right pressure in the skull cavity. So your cerebrospinal fluid, I know we referred to it a little bit on Tuesday night's class, but we'll call it CSF from here. It's just easier. Your CSF is produced in a chamber inside the brain. It's actually not easy to find. It's called the third ventricle. That is the spot of the brain that I was saying that if you just held a brain in your hand, you actually wouldn't see the third ventricle. It's kind of in the middle of the brain. It's between the two hemispheres of the cerebrum, sits anterior to the cerebellum, and kind of a little bit above and in front of where the brainstem connects. So the only way to see it, if you were to dissect a brain, is you actually have to split the brain in half. I know that sounds gruesome, but that's where the CSF is produced. It's approximately 125 to 150 milliliters of CSF in the brain at any given time. You don't have to necessarily know that, but just know that there's a range, right? And that is meant to maintain a certain amount of pressure inside the skull. CSF primarily acts as a shock absorber. It also kind of feeds the brain. That's why I was saying, like, if you're checking on a patient with a crushing face injury, for example, and they're bleeding out the nose, and you want to know if there's CSF fluid in there, um, you can always run a glucometer stick on it and see what your sugar comes out to. If the sugar's really high, there's probably going to be some CSF fluid in there. The problem is, and the reason why we look for that, is your CNS system, your central nervous system, is supposed to be completely confined between the skull and the spinal column. Yeah, your bones don't make an airtight seal, but the dura mater, the or the arachnoid layer, and the pia mater do. So there should not be any CSF anywhere outside of that water balloon that contains your blood, your brain, and your spine. So if you've got it in blood, if it's coming out of the face or coming out of the ears, that means that there's a open access to the brain somewhere in that injury, and CSF is coming out. That's why we check for it. All right, for your peripheral nervous system, so now we're talking about everything other than the spinal cord and the brain. There's 31 pairs of spinal nerves. Can anybody tell me how many vertebrae we have, again, between the thoracic, the lumbar, and the cervical? You can break them apart if you need to. You don't have to do the math in your head. How many cervical spine do we have? Cervical vertebrae. Good, 7. What about thoracic? All right, lumbar. Good. And then we have our sacral and our coccyx, which I don't make y'all remember the numbers for those, but basically it totals up to 30 vertebrae. We have 31 pairs of spinal nerves. anybody wants to try to do a gotcha question on it, one of the pairs sits on top of C1. That's the difference. So the other 30 pairs come out of each vertebrae, but your first spinal nerve pair is sitting on top of the first vertebrae. So these conduct impulses from the skin and the organs to the spinal cord. They also send information back. So we have affectors and effectors. Your affector nerves are the ones that are the cause, right? So if I put my hand on a hot stove, the affect, if you think cause has an A in it, affect has an A in it. The cause is I put my hand on something freaking hot and it's burning my skin. So the nerves in my skin are going to shoot a message to my brain that says, "Hey, idiot, move your hand." The effector nerves are what's causing the effect. The effect of that screech in my skin is I want to move my hand. So that's your nerve ways or two-way streets. Some nerves are going to be all one way, like your optic nerve, right? That's all that's doing is just taking what it sees, it passes to the brain. The brain doesn't tell the optic nerve to do anything. It just receives from it. Other nerves are going to have they're either all the way into the brain or they're all the way out of the brain or they're both. They have two-way streets in them. But that's your primary communication system. And they're just like your vessels. They start off kind of large coming off the spine. And then as they branch out to their specific nerve endings, they get smaller and smaller, just like how your vessels go from giant arteries and veins all the way down to your capillaries. You could actually look at this like a completely separate circulatory system. So I actually like that they do this. If you look at this picture, your spinal cord, as you can see, it actually barely makes it to your lumbar spine. Your spinal cord stops pretty high up. All that flayed out down below it is your nerves. That's your peripheral nerves.
Yeah.
We have 12 pairs of cranial nerves. These are just the nerves that are inside your brain or inside your skull. And these are all one directional. So they transmit information directly to or from the brain. These aren't the two-way nerves that you're going to have the rest of the body. They perform special functions in the head and face like sight, smell, taste, hearing, and facial expressions. So as you can see, based on what they do, they only need to be one way. One of your RO signs with epilepsy is pulling right below your occipital. So you can kind of feel like something's condensing on the back of your. Is that what you mean? It's almost like you feel something pulling, tightening up back there. Oh, that's trippy. Is it to the point where you feel like you need to move your head, or is it just like a tightness? And I guess it makes sense if you're having epilepsy there. Oh, wow. Yeah, I mean, it makes sense. Your cerebellum is a lot of your motor function control. Then that's where that's at. It's down below your occipital lobe. That's interesting. When we go to the boot camp, I'd love to sit down and talk with you more, just to learn more from you on that, because I'm not epileptic, and I have very limited experience in it. I'd love to learn more.
Yeah, I accidentally said shut the fuck up, and I was unmuted.
What did I say?
He texted me. He was like, "She's such a kiss ass."
Sharon, you're unmuted. I mean, we can definitely pause and let you keep going. All right. Anyway, moving on. Let me try to figure out where I left off here. That's awesome. You're fine. You're fine. All right, so we have two types of peripheral nerves. We have the sensory nerves, which are going to be collecting information from the world around you and sending them to your brain. And then your motor nerves, which there's one for each muscle, and they carry information from your brain back to your muscle. So again, like if I put my hand on something hot, the sensory nerves are like, "Hey, Idiot, move your hand. The motor nerves are what actually make me move my hand. So if somebody has nerve degradation due to old injuries or something like that, they may not have that. Old stroke patients. The problem with your nervous system is once those nerves are dead, you don't get them back. It's not like skin cells and muscle cells that it will actually repair. When your neurons actually die off, they are gone. That's it. You don't have that nerve anymore. So if somebody has had an issue that takes away their ability to feel their hand, they're not gonna. If that nerve is actually dead, they're not gonna be able to feel their hand anymore. So they're susceptible to injuries worse than normal if they put their hand on something hot, because that whole "ow, I need to move my hand" aspect isn't there. All right, the connecting nerves are found only in the brain and spinal cord. They connect your sensory and motor nerves with short fibers, and they allow for exchange of simple messages. They're usually myelinated, which means that they have like an extra coating on the outside that makes the electricity fly very quickly through it. Especially when you're dealing with something like a reflex and something where you want to move fast, you want those nerve impulses to get to where they're going as quick as they can. So you're going to find that a lot in your CNS, because all they need to do is get the information out as quick as it can. All right, so your nervous system controls virtually all of the body functions, including your reflex activities, voluntary activities like scratching, lifting weights, walking, all that, and then involuntary activities like your breathing, your heart rate, your digestive tract. All those things are innervated by nerves that you don't have control of. That's your autonomic nervous system. The connecting nerves in the spinal cord form a reflex arc. If a sensory nerve in this arc detects any irritating stimulus, it bypasses the brain and immediately hits the motor nerves and says, move it. So, can y'all hear me? Okay, you can hear me. Somebody do me a favor, because I can't get my cursor to pop up on the text. Tell her it might be a connection. If it's slow, it's going to cut out the audio. Anyway, the way your reflex arcs work is that they bypass the brain. So if, like, when you think about it, you go to the doctor and he hits you in the knee with this little hammer of death and makes you kick across the room. The reflex is the reason it's so fast is because you're not having to wait for your nerve impulse to go from your knee to your brain and then back to your knee. When he hits that one spot, that sensory nerve has a direct connection to the motor nerve, and it just says, hey, move. That's it. You don't need to involve the brain in that. You've got a couple of different reflex arcs all through your body. That's just one of them. Another one is your gag reflex. That's where if something hits your uvula, it goes straight hit. As soon as it hits your vagus nerve kicks back and says, well, get it out of your airway. So that's how your reflexes work. And as long as you have any kind of consciousness, they'll work. Usually it takes you being completely knocked out for you to lose your reflexes. That's why we don't give an OPA to a conscious person or even a slightly unconscious person. They got to be completely out, or they're gonna gag on it. If a sensory nerve, I already said that. Voluntary activities are activities that we consciously perform. So if you say, I'm going to move my hand, and you move your hand, that's a voluntary move. Involuntary, you get to the right. There we go. Involuntary activities are the activities that we don't control, like breathing. You can control your breathing because you're controlling your diaphragm. But if you were to completely get knocked out, if you were to go to sleep and you're not thinking about moving it, you're still breathing, because you have that involuntary control as well. If you were to just hold your breath like a kid wanting to pitch a fit and they hold their breath, and as a parent you just sit back and watch, you're like, all right, you're gonna breathe, let's just see how long you can hold your breath. That's your voluntary versus involuntary kicking in. As long as you're awake, eventually your body will force you to breathe. The somatic nervous system handles your voluntary activities. That's your voluntary side. The brain interprets the sensory information that it receives, and then it sends messages back out to your muscles to do whatever it is that you are wanting it to do. Your autonomic is your involuntary. Again, this is what we don't control. Our brain's doing this whether we're awake, asleep, it doesn't matter. But your autonomic is divided into the two systems of sympathetic or parasympathetic. Remember, just like your muscles, your nervous system can only operate in one direction. So if you want to, if let's say something scares you and your fight or flight kicks in, your sympathetic nervous system kicks in, and that causes your pulse to climb, your blood pressure to climb, your pupils are going to dilate so you can get more light in. Because think about like if you're under attack, if you're being threatened in the dark, you want to be able to see more, right? You can see the threats coming at you, so your pupils are going to dilate. Your heart rate's going to spike. Your breathing's going to pick up. You get into that tensed up mode. Adrenaline causes it. That's your sympathetic nervous system. But that's all it knows how to do. It's just going to keep going in that direction. So to keep it under control, to bring things back down to your baseline, we have our parasympathetic nervous system. And it's just equal and opposite. So they're locked in total tug of war for the duration of your lifespan. And based on what hormone gets released at what time as needed, it will give one more strength than the other. So one side will start to win that tug of war over the other one. All right. For your skull, this would be the third time that we've gone over the anatomy of the skull, so I'm not going to really bother too much with it. Just know that your skull is all fixed bones with the exception of your mandible. It's the only bone that should have any kind of movement. We talked about the vertebrae, 7, 12, and 5 for your cervical, thoracic, and lumbar. Your sacral and your coccygeal are fused, so I don't bother making anybody learn those. But there they are if you want them. If you injure a vertebrae, it can result in paralysis because it's going to pinch your cord. The vertebrae are connected by ligaments because that's what connects bone to bone. And they're separated by cushions called intervertebral discs. So if you've ever heard somebody say that they slipped a disc, or if any of you guys have done that, these discs that cushion each vertebrae, that's what you're talking about. And it can be a couple things. It may be that one got kicked off to the side, which you can actually fix without a surgery. You don't need surgery for a actually slipped disc. But if you rupture a disc where you pop it and all the fluids that make it a cushion leak out of it, now that disc is flat and empty, then that requires a surgery. But sometimes you'll get patients that tell you that they have a slipped disc and they had to go to surgery, which really means that they ruptured the disc. They didn't slip it. If they slipped it, there's a couple of stretches you can do that will fix that. All right, so let's get into the head injuries. This is the reason why they're calling 911. A head injury is a traumatic insult to the head that may result in an injury to soft tissue, bone structures, or the brain. Anything up there at any level can get hurt. Approximately 4 million people experience head injuries of varying severity in the United States each year, and 52,000 of them die. Head injuries account for more than half of all traumatic deaths. Usually, if you get into a vehicle accident and all your injuries are from the neck down, or at least from the shoulders down, you're probably going to survive unless it's some really, really massive trauma. But if you have if you get hit in the head with the same impact that would break your leg, you actually do have a high risk of death. So these are serious matters, and they're hard. They're really hard to deal with in EMS, especially at your level. But there's a couple of things you can learn, a couple of things to watch out for, a couple of things you can do that will make your patient's outcome much better, to make life a lot easier on your paramedic, and it'll make you look like a rock star to the ER. So just like anything else, you have closed and open head injuries. Just depends on if the skin's broken or not. So in closed injuries, we're talking like blunt force trauma. The brain is injured, but there's no opening into the brain. The skin's not broken, the skull's not broken. They just got hit real hard. Open injuries, this is more of your penetrating injuries. So they got shot, or something got through the skull, and there's an opening to the outside world from there. Motor vehicle crashes are the most common that you're going to see TBIs in, at least as far as civilians go. You guys that have been in the military and deployed, a lot of your TBIs are from blast injuries, IEDs, things like that. But over here, where that's not a common everyday occurrence, mostly it's just going to be car wrecks. More than 2/3 of people involved in car accidents experience a head injury. And head injuries also occur commonly in victims of assault, when elderly people fall, during sports-related incidents like football, and in a variety of incidents involving children. Any head injury is potentially serious if it's not treated. This was always a scary thing for me when I was an early EMT, because we'd go out to a scene, and I was always, with the exception of when I worked for a couple ambulance companies, but most of my career has been fire-based. We weren't transport. So we'd be on the scene with our patients sometimes for 30, 45 minutes before the ambulance showed up. And, you always know, oh, don't let your patient go to sleep. They may have a concussion or something like that. But when they're acting really, really weird, not just in their behavior, but also their vital signs, it's pretty scary when you're it for 30 to 45 minutes while you're waiting on the ambulance. Remember that, Wesley, you got firefighters getting on the radio and they're like, ETA on the ambulance, and they're asking every 2 minutes. It's probably because what they're seeing in front of them is throwing them for a loop. So usually that means you're going to have an interesting call when you get there. Scalp lacerations can be minor or serious. It just depends. There is muscle between your skin and your skull. So you can get a pretty deep gash, pretty bad, severe injury there without ever even making it to the bone. A lot of people think that, that's it. It's just this little bitty thin layer, and it's not as thick as, say, like your bicep, but it is pretty good amount. Even small lacerations can quickly lead to significant blood loss because of how many vessels are up there. Occasionally, this blood loss may be severe to the point where you may have shock, especially in kids. And that's the thing. We'll talk more about it when we get to peds, but you'll find that most of the time, most traumatic injuries in children have to do with their head. They're just bigger, they're heavier in relation to the rest of the body. So they're more likely to get hit. They're more likely to have the neck injuries. If they fall from a big height, they're usually going to land head first. If they're small kids, if they're a little bit bigger, they'll probably land feet first. But the way that kids try to land is they, for whatever reason, think that if they lock their legs out, they'll be okay. And they cause more damage that way. Skull fractures, these are significant force applied to the head, bad enough to break the skull. They may just be an imprint, kind of like how, if you've ever seen Star Wars, you know how the Death Star had that one circular imprint on it. Looks like something hit it. A skull fracture can be something like that. It can be a complete breakaway where the bone is in the brain. It can be just a splinter, just any range of that. A skull fracture may be open or closed, depending on whether there is an overlying laceration of the scalp. And injuries from bullets or other penetrating weapons frequently result in fracture of the skull, even if it doesn't get all the way through it. Signs of skull fractures include the patient's head being deformed. So the very first letter of DCAT BTLS being deformities is one of the things you're looking for. All right. If they look like they've got a cone head, like our patient at Best Equipment that got his head stuck between a wall and an I-beam, that he looked like a cone head when we got to him. There can be visible cracks in the skull if there's a break in the skin and you can see the skull. That's usually a bad day. Ecchymosis, bruising that develops under the eye. We call those raccoon eyes because it kind of looks like they're wearing the mask like a raccoon. And then ecchymosis that develops behind one ear over the mastoid process, which we call battle sign. So if you ever hear either of those, we're referring to blood pooling up underneath the skin in one of those two locations. Battle signs behind the ears, raccoon eyes obviously around the eyes. So there's an example. That's a pretty severe case of raccoon eyes. The few times that I've come across those weren't that bad, but it's a good example. And then that battle sign on the ear, that's pretty common for what it looks like. If you're going to see battle signs, it's going to look about like that. All right, so linear skull fractures are non-displaced. In other words, the bone is still in place. It just has a crack in it. These account for approximately 80% of all of your fractures to the skull, and we don't normally see these in the field. This usually takes an X-ray. So radiographs, X-rays are required to diagnose a linear skull fracture. You can make the assumption that they're there. Sometimes if you're losing CSF fluid, you can, but you don't see any deformities, you can kind of assume that there might be a linear skull fracture where the leak is at. But outside of that, we can't really tell. Depressed skull fractures, these result from high energy direct trauma to the head with a blunt object. And again, that could be anything from a bullet to the vehicle itself, the tree that you went through, any of those. The frontal and parietal bones of the skull are the most susceptible. Here's an interesting thing about bone thickness. Frontal bone and your parietal bones, which is the front of your head, like your forehead, and the sides of your head. Those bones aren't that thick. Though your skull gets thicker as you get around to the backside. When you get around to the occipital lobe, that's the thickest part of the bone. So if you're going to have a depressed skull fracture, it's much more likely that it's going to happen from an impact to either the sides or the front of the head. The back of the head doesn't. If you get a skull fracture, like a full-on depressed skull fracture there, the amount of damage, the amount of energy transference that gets through is going to be you're probably not going to survive. I mean, if you do, you're not going to be very, very well off. Basilar skull fractures. These aren't fractures that you're going to be able to see in the main cranium because this is your basilar skull. There's one part at the bottom of the cranium, right behind the nose. It's called the cribriform plate, and it's paper thin. The reason that the body has never built up the thickness of that is because it just doesn't need to. It's naturally protected by the rest of the head. But depending on how they get hit, the trajectory of what hits them, they can fracture that cribriform plate. And that's actually the bone that we worry about putting our NPAs through. So when you're trying to put the NPA in somebody's nose, if you keep hitting resistance and you think that they've got that basilar skull fracture, that's the problem. All right, open skull fractures. Open fractures of the cranial vault result when severe forces are applied to the head and are often associated with trauma to multiple body systems. Again, think about how much damage, how much energy it takes to get that kind of an impact into the skull. If that's what you're looking at, say somebody, the only times I've ever come across these outside of a battlefield were when people tried to shoot themselves, like suicide attempts. They put the weapon right up against their skull and pull the trigger. They've got an open skull fracture, and there's brain matter laying out beside them and stuff like that. Those are gruesome calls, but they have a small MOI technically, not a mild one, but a small compact one. It's not like a massive car accident or anything. But if you get these, they do have a high mortality rate. Again, that amount of energy usually gets transferred to the brain, and even if you can get them back, the damage to the brain from that impact is hard to come back from. All right, so TBIs, these are the most serious of all head injuries. They're in a class all their own. Your DCAT BTLS is not going to depict these. This is something that you just kind of have to know, like you know diabetes. All right. The National Head Injury Foundation defines a TBI as a traumatic insult to the brain capable of producing physical, intellectual, emotional, social, and vocational changes. And again, like I said, this is the worst of them all. They're classified into two broad categories. We have primary injury and secondary injury. Your primary brain injury results instantaneously from the impact. So the actual traumatic impact is your primary. Your secondary brain injury increases the severity of the primary and may be caused by either cerebral edema, intracranial hemorrhage, infection, increased intracranial pressure, that kind of thing. So, here you go. Hypoxia can do it. It's not the injury, it's the surrounding circumstances in addition to the injury. So if you get knocked out and you're not breathing properly, hypoxia will make the head injury worse. Hypotension can make the head injury worse. Intracranial hemorrhage and increased intracranial pressure, which the hemorrhage will cause the pressure. Those will eventually lead to the hernias, like I was saying. Wait a minute. The slide you showed the bruised ears and eyes one time, what was that again? Oh, let me go back to it. This one. All right, so the bruised eyes are called raccoon eyes. Hence, that's why they look the way they do. You look like a raccoon. And then your battle sign is behind the ears. They can. It depends on how that damage got spread around and where the impact was. The bleeding by itself, not necessarily going to cause you to lose your eye. But let's say they got hit in the back of the head. The pressure could pop their eye out of socket, depending on any other, like let's say they're in a rollover, any other injuries could finish it off. Yeah, they could lose their eye. I'm a little confused because the way they list these, so these injuries aren't TBIs. I tell you what, Wesley, why don't you unmute? Let's have a conversation on this real quick.
Yo.
What's up, dude? All right. So, what's the confusing part?
Well, I was asking more or less like with these types of injuries, like in a skull fracture and stuff, could that be like the cause for somebody to lose their eye? Because recently on a motor vehicle accident, we had guy had a closed skull fracture. He had this same type of bruising around his eyes, things like that. He had a pneumothorax. So when he had Kussmaul respirations or whatever, we couldn't dart him because he was also hypoxic, and we thought that he might have had blood in his lungs. But he ended up, one of the worst things that ended up happening was he lost his left eye. And, well, along with the fact he didn't make it, but I was just wondering more or less, was that the raccoon eyes due to his head injury, what would have caused him to lose the eye? Because it was intact when the wreck happened.
Yeah, so the raccoon eyes are a symptom. They're not a cause of things. That's just bleeding. If there's blood loss there to affect the eye, like maybe it pinched off the vessels that were feeding the eye and it went ischemic, the cells died from that. That's a possibility. And I'm sorry, Winston, I didn't realize that it was you. I'll pick you up in here in just a second. But no, typically the raccoon eyes are a sign. They're not part of the injury. They're just another sign of it. So depending on what caused the raccoon eyes, where the bleed was that caused that, could have been blood that was supposed to feed that eye.
Right. He's bleeding out of both ears, so I figured it was probably pretty bad if he had that and the ear bleeds.
Yeah, just depends on where those breaks were.
All right, dude.
Now for let's see, Winston, for you, go ahead. Can you unmute, Winston? Are you able to do that, or can you only type? I don't have a mic. Okay, no. Well, that's fine. I just thought maybe you could say it easier if you could unmute. So with what you wrote, a little confused because the way they list these, so these injuries here aren't TBIs. Are you referring to what we're looking at here with the raccoon sign or raccoon eyes and the battle sign? Yes, that's true. And maybe that's just maybe they could rearrange the slides a little bit better. But the raccoon eyes and the battle signs, these are signs of a TBI and a skull fracture, mostly a skull fracture because this is how blood's getting out of the skull. But these are tied in very closely with a TBI. So in a sense, yeah, they're not TBIs, but they come with it. Just kind of like how a stomach ache comes with food poisoning. It's just something that goes with it. Not always, If there's no bleeding, then you don't have that. You don't have these signs. These are just outward signs that you can see from the blood loss. Keep in mind, a TBI is a blanket term, right? Traumatic brain injury is just a title of exactly that. So it can be, okay, so the linear, depressed, open, and basilar, those are your skull fractures. Those are just breaks in the bone. You can have breaks in the bone that don't actually do anything to the brain. A TBI is when the injury makes it to the brain itself, and that may be where the breakdown is. So these two signs right here, you're only going to see these if the skull fractures. The brain may not. Usually, yes, there's going to be a brain injury there, but there is always that chance that they got hit in just the right way, that the skull managed to absorb all the blow, but not without getting broken in the process. Well, it's more like not only the different causes and types, no problem. It's just different things getting hit. The stuff that we were talking about there were the different breaks in the bone itself, not necessarily the brain. Now we're getting deeper. So we've gone past injuries that would only damage the bone. Now we're going into the injuries that the energy transference actually damages the brain itself as well. All right, so back on this. Great questions. By all means, stop me if something doesn't make sense. We can go back and talk about it. So your TBIs are your most serious of all brain injuries. Um, these are the deepest ones. These are the ones that, the skull, the Dura Mater and everything just completely failed to do what it was able to do or what it was designed to do, because the impact was just that strong that it made it through your defenses and it got to your brain. So you have your two broad categories. You have your primary, which is the impact itself, and then you have the secondary, which is your other things that can make that bad situation even worse. So again, you have your cerebral edema, which is bleeding in the brain, intracranial hemorrhage, increased intracranial pressure, cerebral ischemia, which is it's caused by bleeding, but it's the opposite of it. It means that there's no blood, the blood's not getting where it needs to go. And then infection. With this one thing here, especially these open skull fractures, you really have a high risk of infection. That's supposed to be a closed up system. You really shouldn't have any outside air or things getting in there. Hypoxia and hypotension are the two most common causes of secondary brain injury. So, I mean, the good thing is those are two things that we can really do a lot to fix in the field, right? I know it sucks when you think that all you can do is give oxygen, but sometimes that's exactly what they need. Where if a paramedic just sat down and shoved you out of the way, and he would do the exact same thing, just give them oxygen. Secondary brain injury may occur a few minutes to several days following the initial injury. It depends on what's damaged. And again, I want you to kind of think about what we talked about with where your arteries are versus your veins, because now we're going to start getting into why that matters. The brain can be injured directly by a penetrating object, such as a bullet, knife, or other sharp object, or indirectly as a result of external forces. So your blunt force traumas that hit the head, the objects may not make it to the brain, but the energy transference does. A coupe countercoup injury can result from striking a windshield in a car crash. So those of us in EMS and the fire service, this is what you see if people get hit from behind, where they have the whiplash, or in this case, like it's saying, like you get hit, you go forward, you smack the windshield. Now the anterior portion of your brain is injured, and then you come back and you hit the headrest real hard, and now the posterior portion of your brain is injured as well. So the front and the back are now bruised, could possibly have bleeding in those areas, and it gets hard to diagnose because you're looking at signs that, you're like, okay, well, I'm looking at this. That tells me that the anterior portion of the brain is hurt, but he's also doing this. So that tells me that you get kind of wrapped around the axle with it. So try not to spend too much time trying to figure out what the damage is. Just recognize, if it doesn't make sense, just recognize there is damage, probably to multiple areas of the brain, especially when you deal with unrestrained drivers who get thrown around. they're going to have problems all over the place. And their vitals, the only sense you're going to make out of their vital signs is that they're screwed up. That's all you get. It won't be as pretty as saying, well, this area of the brain is hurt, and so I get these nice symptoms, and it tells me that that's exactly what it is because there's nothing else. In the real world, it doesn't ever really work out that pretty. All right, for intracranial pressure, this is where the blood vessels come in. All right, so I have method to my madness here. Accumulations of blood within the skull or swelling of the brain can rapidly lead to an increase in ICP, which is intracranial pressure. Increased ICP squeezes the brain against bony prominences within the cranium. Again, you got your brain. Your brain doesn't take up all the space in your cranium. You still have that room for your CSF to be that nice little shock absorber, liquid shock absorber. And there's a nice balance. There's a nice pressure that's maintained there. But when you introduce something else to it, like say blood, for example, because you got hit, you sheared a blood vessel, and now you're losing blood into the brain. It's going to build the pressure because the skull won't expand to allow the pressure to equalize. So as more stuff pours in, it's just going to get more and more compressed. And what that's going to do is it's going to put pressure on the brain. And if it goes about long enough and nothing is done to stop it, eventually it's going to get so bad that it's got to go somewhere. And it's going to go the path of least resistance, which is not to break a piece of the skull away. It's to go out of that massive hole at the bottom, which is we call the Foramen Magnum. And the brain is going to get shoved down into the neck because that's the only place it's got to go. Now, if you think back to the anatomy of it, when we talked about the brain stem and how it sits right inside the Foramen Magnum, right inside the skull, it's the first thing. If the brain were to ever try to leave, the Foramen Magnum would be the first thing to get shoved out. And that's where most of your life processes are, right? We talked about your RAS being there for your consciousness. All your vital signs are controlled right there. So if it gets bad enough for a hernia to happen, that's where you start to see the real bad signs of like posturing. If you've ever heard decorticate and decerebit, which we'll talk about, that's going to come up in this chapter tonight. And their vital signs are, blood pressure is like 200 and something over 180 and pulse is freaking out. You run into those things and there's nothing, once they get to that point, there's really not a lot we can do with it. Wes, there probably wasn't much you could do with it. A lot of times it's just hurry up and get them to the hospital so that they can start popping holes in the skull to relieve some of the pressure. There's things that we can do to try to help slow the bleed, but there's nothing we can do to pull them back from that. So it's just like dealing with shock. Everything that we do in the field is to try to stop it from getting there in the first place. Because once it does, it gets worse and worse. So you start to see in posture. Usually that's the pucker factor that you tell the driver to get you to the hospital as fast as they can without killing you in the process. Some signs of increased ICP. You have Cheyne-Stokes respirations, ataxic or Biot respiration. So again, these are not normal respirations. Cheyne-Stokes is where they're deep breath. They're tachypnic. They're breathing very fast, but they're breathing very deep. Remember, usually when people breathe fast, their breaths get shallow because they're still trying to maintain that minute volume. If you increase one number, the other number will drop down to maintain the status quo. Cheyne-Stokes is the other way around. You spike up your rate and your depth because your body's thinking that it's got a lot more CO2 than it does and it's trying to blow it all off. Ataxic respirations, there's no rhyme or reason to them. You'll start off real deep breaths and then you'll go down to shallow breaths and then back up to real deep breaths and back down to shallow breaths and so on and so on. Decreased pulse rate, headache, nausea, vomiting, decreased alertness, bradycardia, sluggish or non-reactive pupils that don't react the way that they should. So like if one constricts and the other one doesn't, that kind of thing. Decerebit posturing, decorticate posturing, and increased or widened blood pressure. There's entire classes on this stuff, and I'm not going to make you guys masters of it tonight. I just want to kind of get you as exposed to it as I can. A couple of things about these. You're not always going to see these signs. Sometimes you'll see some without the others. So when we talked about pertinent negatives, nausea and vomiting are both in this list. But a bigger red flag would be if you had the vomiting without the nausea, because usually nausea relates to something with your digestive tract. Um, let's see what else is in here. Bradycardia, and I know it says actually it doesn't say it. So with the bradycardia comes a higher blood pressure. So in other words, like you're checking their pulse and you feel it doesn't feel like a normal pulse. Every time you feel it, it feels like a jackhammer. And if you were to take their blood pressure, their systolic is going to be through the roof. Because what's happening is the heart's beating less times, but it's really hammering it in every single beat. Usually that's because the brain is saying, "Give me blood, we need blood," but the heart, by its normal pressure, can't get blood into the skull because there's too much pressure inside the skull. It won't. It's putting pressure on the vessels. The blood can't get in there, so the heart slows down and it starts really trying to hammer it in. That's a sign that you have a head injury. Is when you start to see that. Cushing reflex. There's a couple of triads out there we used to teach. This one, I think, is actually the only one that's in this curriculum now. But Cushing's reflex. This is a triad of increased systolic blood pressure, decreased pulse rate, and an irregular respiration. That's what we were just talking about. So your pulse slows down, starts hammering it in harder, trying to just get whatever it can into the pressure zone that's already built up in the skull. And then because your brain is getting all that getting crunched, your respiration is get kind of out of whack. Intracranial hemorrhage. When we get through the set of 7 slides, we'll take our break because it's already 7 o'clock. So blood inside the skull is also increases the ICP. Again, anything you add to the skull, if something can't leave, it's going to build up the pressure. Bleeding can occur between the skull and the dura mater, beneath the dura mater, but outside the brain, or within the tissue of the brain itself. So think about your different types of bleeds. What do you think you're going to lose blood from the fastest, your arteries or your veins? Arteries.
Artery.
Good, good. So if I said that I had a subdural hematoma versus an epidural hematoma, which one do you think is worse? Think about where your arteries are. Are they below the dura, or are they up around it and up inside of it, away from the brain? Remember, your veins are deeper, right? Your veins are deeper. Your arteries are out closer to the skull. So if I have a subdural hematoma, which means that I'm bleeding from deeper inside the skull, below the dura, I'm bleeding from a vein. Veins have lower blood pressure. That's all right. That's all right. That's why I'm bringing it up. Veins have lower blood pressure. They're not going to bleed out as fast. So the onset will be drawn out. All right. If you have a subdural hematoma, this is something you can't see it in the field. This is something that they have to do MRIs to see. But you can, if you know what they do, you can look at your patient and be like, I don't know for sure, but I'm going to operate like you've got a subdural hematoma because that's what it looks like. If it walks like a duck, talks like a duck, it's a duck. So basically, if you have a subdural hematoma, you're bleeding from the veins, and what that means that they're going to have a slower onset. They're probably not going to have passed out. You're getting into those kind of concussion type signs where it's like, yeah, I got hit 5 hours ago, and no, I didn't pass out, but I'm just really sleepy. I'm sluggish and all that. Yeah, they're probably bleeding from veins inside the brain. And it's causing a slower onset. And those are the scary ones because people tend to write those off, especially if it's a small bleed. It may be days before they really start to see symptoms, and they already forgot that they got hit in the head. Whereas epidural hematomas, those are bleeding from on either at the dura or above it. closer to the skull, those are your arteries. When you bleed there, you're losing a lot of blood really fast, and so your symptoms come on a lot faster, and they include being knocked unconscious. You may have somebody they got hit in the head, they were in a bad car wreck, they were fine for a little bit, then they passed out, and then they woke up again, and um, and then passed out again or something like that. Those are epidural hematomas. Those are arterial bleeds. They come on faster. The symptoms are worse, and they're gonna die on you faster. The good thing about it is though is that if that's what you're looking at, even your patient's gonna be like, yeah, I need to go to the doctor. This ain't right. So um, you'll have an easier time getting your patient to go to the ER with you. Subdural hematomas, those slower onset ones, sometimes you being the trained person need to be able to recognize that those slow onset symptoms don't necessarily mean they're just sick. They could actually, if they got hit recently, they could be having some serious problems because they may be fine when you leave and then be dead by the next morning. It just depends how bad it's gotten in that length of time. So here's your epidural hematoma. We just talked about that. Um, these are arterial bleeds. They happen fast. Your patient loses consciousness immediately after the injury. They may not stay unconscious, but they'll lose it. Your subdural hematomas, this is bleeding below the dura. These are by the veins. Like I said, they usually don't have a fast onset. And then you have your intracerebral hematomas. This involves bleeding from within the brain itself. Um, this can occur following a penetrating injury to the head, like if they got shot, or because of rapid deceleration forces from a car wreck. Many small, deep intracerebral hemorrhages are associated with other brain injuries. Intracerebral hematomas have a high mortality rate, even if the hematoma is surgically evacuated. Because if they have to go in and cut into the middle of your brain to get the hematoma out, they're probably it's just the amount of collateral damage usually is really bad. All right, and then we have subarachnoid hematoma. Um, Bleeding occurs into the subarachnoid space. This is that spiderwebby area, remember, where the CSF circulates. This results in bloody CSF and signs of meningeal irritation. So you're going to have a lot of pain. If there's a skull fracture there, you're going to see some CSF coming out of it. Common causes include trauma or rupture of an aneurysm. So sometimes it may not even be that they got hit. It could just be that they had an aneurysm in one of their vessels. Patient reports a sudden severe headache. It comes on fast because you're still up there in that arterial space. So it's a fast onset, and the subarachnoid hemorrhages, they hurt. They feel like your patient's going to would rather have a shotgun to the face than the pain that they're feeling. A sudden severe subarachnoid hematoma usually results in death. Survivors often have permanent neurologic impairment. So even if you got them to the hospital quick, unless there's a neurologist and a team of surgeons standing at the door waiting on you, the outcome is probably not going to be very good. All right, take a 10-minute break and then some. We'll get back started at 7:20 and we'll continue on with concussions. All right. So we're going to get back to it. Working on, oops. Let me reconnect everything here. All right. All right. So moving on with concussions. This is a blow to the head or face, or a blow to the head or the face can cause a concussion of the brain. Concussions are also known as mild TBIs. So typically, a concussion is not going to lead you down the road that like a subdural hematoma would do, or an epidural, and you're not going to get the posturing and all that stuff. But don't let that make you think that it won't turn into something major, right? Concussions still have to be taken care of. Um, it's just that your patient is probably they're not gonna die on you in the truck, not from a concussion. In general, it's a closed injury with a temporary loss or alteration of part or all of the brain's ability to function without demonstrating physical damage to the brain. So there's no, like, a lot of times concussions don't really show up in an MRI. It's think of it more like a bruise versus a broken bone. A patient with a concussion may be confused or even have some amnesia. Occasionally, the patient may have retrograde amnesia, which means he or she can't remember anything leading up to the injury. Amnesia from any, like, if you get hit and it wipes out everything in your short-term memory that happened leading up to it, that's retrograde. And then there's inability to remember events after the injury, which is called anterograde, which is post-traumatic, right? I mean, like, not PTSD, but post-traumatic being after the event. Usually a concussion lasts only a short time. After a couple of days tops, usually the signs of the concussion are gone. You should ask about symptoms of concussion in any patient who has sustained an injury to the head, including dizziness, weakness, visual changes, nausea, vomiting, ringing in the ears, slurred speech, inability to focus, lack of coordination, delay of motor functions, inappropriate emotional responses, temporary headache, or disorientation. Disorientation being when we think about when we say their A&O times 3 or 4, or whatever you want to use, their orientation to person, place, time, and event. That's what they're referring to there. You should assume that the patient with signs or symptoms of a concussion has a more serious injury until proven otherwise. Remember, those subdural hematomas can take days to manifest. They could start with a concussion and then grow from there. Contusions, like any other soft tissue in the body, the brain can sustain a contusion or bruise when the skull is struck. A contusion is far more serious than a concussion because the blood loss there, first of all, you've got two problems. One is the blood's not where it needs to be in the vessels going to the cells. Two, any blood outside the vessels is just more pressure in the brain cavity. Not to mention the fact that blood is an irritant. If blood gets outside of the vessels, it hurts. So your patient may have some pain associated with the bruising. This can produce long-lasting and even permanent damage, especially if it's a whole bed of vessels that's been damaged. It's going to be a while before any blood flow gets restored to that area. By the time it does, they may have already lost access to that section of the brain, at least at full capacity. A patient who has sustained a brain contusion may exhibit any or all of the signs of a brain injury. All right, so then some other injuries. Brain injuries can also arise from medical conditions like blood clots or hemorrhages. You can get brain injuries from certain illnesses like meningitis. Problems with the blood vessels, high blood pressure, or other problems may cause spontaneous bleeding into the brain, affecting the patient's level of consciousness. Some medications can do this. This is known as altered mental status. And then the signs and symptoms of non-traumatic injuries are often the same as those of TBIs, There just really won't be an MOI for you to assign to it and say like, all right, well, you look like you have the signs of somebody who hit their head, but you're just sitting in your recliner. So there's no injuries there. For your spine, you have the cervical, thoracic, and lumbar portions of the spine can be injured in a variety of ways. So compression injuries can result from a fall, regardless of whether the patient landed on his feet, head. You could even land flat. You can still get a compression injury. It just depends on how you hit and how that force is going to push through you. Forces that compress the patient's vertebral body can cause herniation of discs, subsequent compression on the spinal cord and the nerve roots, and fragmentation onto the spinal cord or spinal canal. So if you have a kid, for example, that falls off the roof because they were climbing up there, they fall down, and they're trying to land on their feet because they know that that's going to be the less damaging. Let me get this fixed real quick. Sorry. All right. They know that they think that landing on their feet is going to be better than landing on their head, which is accurate. That's true. But it doesn't mean they're not going to have injuries. That's called the Don Juan injury. When you land on your heels and that impact goes through the length of your legs, they have the risk of popping their legs out of their socket. And because of the continuation, that inertia, um, the continuation of their upper body going down until it meets enough resistance from what's below it to stop, the spine is going to condense down and it can pop vertebral discs. It can slip them out of the way. It can knock vertebrae out of the way. And if it does that, they'll pinch the cords. So obviously this can happen at any age. I used a child as an example, but that's basically what they're referring to here. Motor vehicle crashes or other types of trauma can overextend the cervical spine and damage the ligaments and joints. Rotation or flexion injuries of the spine result from rapid acceleration forces, and they're most likely to happen to C1 and C2. Remember those two, C1 and C2, that's your atlas and your axis. They're what allow you to move your head. One allows you to rotate your head side to side, and the other one is what allows you to do head like a nod, and it also is shaped to hold your head. But if you think about if you look at your neck and your head, you don't worry about your torso or anything because that doesn't do anything to protect your head. Your head is a giant round bone with a brain sitting on top of a much smaller base. So sometimes it's very hard for that base, that neck, to withstand a hard force if the head suddenly lurches to one side or the other. That's why as far as your spine is concerned, those two cervical spine are the most likely to get hurt. Injuries to this area of the spine are considered unstable due to the location and the lack of bony and soft tissue support. And any one of those unnatural motions, as well as excessive lateral bending, can result in fractures or neurologic deficit. When the spine is pulled along its length, where it extends, there used to be torture practices that did that. It can cause fractures in the spine as well as ligament and muscle injuries. So if you've ever watched those movies or read in the history books where people were put on these torture devices where their feet and hands were strapped in and they were pulled apart, this is the damage that would have been done in those days. When bones of the spine are altered from traumatic forces, they can fracture or move out of place. So if an injury pinches or pulls the cord, permanent damage may occur. Usually we're designed not to let anything get to our cord, but sometimes, your body is not naturally designed to protect you from a car accident. Sometimes things happen. Common findings include pain and tenderness, especially when you press on it. And you may feel or observe a deformity of the spine, which is what we call step-offs. Remember, we talked about that in the neck, how you just kind of run your fingers along the spine, and you're trying to feel to see if any one of those vertebrae is kicked out from where the rest of them are. If you suspect these types of injuries, take extra precautions when stabilizing the spine, and that can either be with a C-collar, long spine board. That would be one of the times you would use it if you had a step off somewhere down in the back. A long would be appropriate for that. All right, for your scene size up, always suspect a possible head injury or spine injury anytime you're encountering one of the following MOIs. So if you show up on scene and you see that there's been an accident, like a vehicle accident, especially motorcycles, snowmobiles, and all-terrain vehicles, four-wheelers, that kind of thing, high risk of head injury and spine injury. Pedestrian versus vehicles, any fall, I will say greater than 3 times your body height is typically what they go with. They do have other ways of measuring that. So like sometimes you'll hear 15 or 20 feet for adults, 10 feet for pediatrics. You kind of get into a gray area there because a 17-year-old is still considered a pediatric, but they're going to have long since become the same size as an adult. Blunt trauma, penetrating trauma to the head, neck, back, or torso. Rapid deceleration injuries or hangings. Those are issues that there's something you're going to want to look for. Your assessment's going to go the same as it does with everything else, be it medical, trauma. Everything starts with BSI, scene safety. So make sure the scene is safe for you. Try to, if there is something hazardous on the scene and you can mitigate it, then mitigate it. If you can't, if it's something you can't control, then maybe don't go in just yet. Get somebody there that can handle it. If it's the cops, the fire department, a hazmat scene, whatever. Call for ALS as soon as possible. The main reason being is because some of the things that we can do to hold off the TBIs is ALS interventions. Even some of the things that we can do as EMT basics, we need a paramedic there to let us know that we're doing it right, because they're the ones that know how to operate their monitors. They're setting up end-tidal CO2. Those are advanced skills, unfortunately, because they don't trust EMTs with it yet. But you're going to want them there to hook all that stuff up. So get them out as quick as you can. Look at your MOI. Decide if it's bad enough to warrant going to the hospital. If it doesn't look like it was that big of a deal or whatever, that's going to help you form your general impression of the scene. For your primary assessment, this is your level of consciousness and your ABCs. Same as anything. Remember, when you're showing up to your patient in a trauma scenario, you want to do a real quick scan for any kind of hemorrhage that might be life-threatening. Even though you're not on C yet, you're still going to do ABC. Just look for that hemorrhage, because if you need to put a tourniquet on somebody, you should probably make that the first thing you do. But as soon as you have ruled out external hemorrhage, then you move into your ABCs and fix one before you move on. So the first thing we're going to do is open the airway. Once we've got the airway open, then you put an adjunct in to maintain it. Then we move on to their breathing, make sure that they're breathing adequately. Once that's taken care of, then we move on to circulation, make sure that they've got good blood flow, at least to their neck. Again, when you guys take your pulses, not every EMT or paramedic is going to say the same thing. In fact, me and Trevor Sansom, who some of you guys are going to meet him at boot camp, this is an area that we disagree on. He says just check the neck. I say check the neck and the wrist at the same time. You're not wasting any time, but you're getting a very good idea about the state of shock that they're in. He says don't waste your time on it. So up to you. Love to hear how colorful he gets. He's going to know you all learned it from me if you do it. So anyway, reduction of on-scene time and recognition of a critical patient increases the patient's chances of survival, or a reduction in the amount of irreversible damage. Remember what I said at the beginning of the night, your nerve cells don't replenish. Once they're dead and gone, they're dead and gone. Spinal mobilization considerations, this has changed over the years. So something that I want you guys to think about is, if you try to figure out where they're having the problem at. If it's just a neck injury, if you're only worried about their C-spine, then put a collar on them and let that be it. If you think that they may have an injury down around the shoulders and their thoracic spine, then maybe a short board would work for them, or a KED. If they're complaining of lower back pain, or you have an issue with their hips, any of that sort of stuff, then you're going to pull out the long board. Other than that, the long board is really only good for moving a patient, like what we did on that call on the interstate, Wesley, when we used a long board to get him out of his car, but we didn't actually strap him to it because we weren't going to. That's not how they were going to transport him. The board is still useful. You're just not going to strap every patient to them like we used to do. Let me make sure I'm in the right spot here. The backboard is rigid and often places the patient in an anatomically incorrect position for a long period of time. Once we decide to use it as an intervention, we can't take it off. The doctor at the ER has to take it off, and they're in a position that really doesn't work well for their ability to breathe, especially if you have an elderly person with a curvature in the spine or something of that sort. You're very likely to make them suffocate. You're going to asphyxiate them by putting them on the board. Yeah, the arguments against there's some agencies that don't even carry the longboard anymore. They let the fire department carry it. If they need it, they'll just grab it off the fire truck, but the ambulance company won't carry them. People say stretcher pad is better. Yep, absolutely. It does, but even then, if you're going to really do some like a massive rescue, you're going to use a sked or a Stokes basket or something like that. You still don't technically need a longboard. They do have their uses. I don't agree with getting rid of them, but yeah, we actually don't need them anywhere near what we thought we did as far as like how often. Circulation to areas of the skin may become compromised, leading to complaints of pain. Some patients, especially bariatric patients, could experience respiratory compromise. And consider placing padding under the patient to help minimize the risk of injury. If you have to use the board, you can pad them up. All right. If you can get away without using the board, don't neglect your patient. But if you can get away with not needing the board, then just don't use the board. It's easier. All right. Apply your cervical collar as soon as you have assessed the airway, breathing, and provided necessary treatment. So we're going to go over this at the boot camp on how the best way to flow through this is. But what we usually do in the field is the minute you get to, like, we'll say there's a car wreck. The first thing you do is you grab the patient's head and you hold it still, right? So you're providing manual cervical stabilization. That's where you don't have a collar on them, but you yourself, with your hands on the side of their head, you're keeping their head straight. But you can't stay there the whole time. So eventually you're going to have to move. If you're doing this with a partner, what I like to do is I would say, have my partner maintain manual stabilization. Now your partner's holding the head and he's stuck there or she's stuck there, and you can continue your assessment. Once you finish your primary, you've checked your ABCs, then you can put the C collar on there. Does anybody think that your partner can let go of their head once the C collar is on? Is that the clear to let go of their head, or should you still hold on to it? Yeah, exactly. Yeah, C collar doesn't mean you can let go of the head. Still have to stabilize it. The C collar is not that good. Like if any of you ever put one on for training, you'll find you can still move your head easily. It limits you, but it doesn't stop you. And Sharon, for your question, it becomes a judgment call. So I try to figure out where their pain is at based on what their chief complaint is, and my assessment. If they're hurting in the neck, or if I think they need a C collar, I'll put a C collar on them. If they're not complaining of any lower back pain, but I think they may have a damaged spine in their thoracic area, I'll put a short collar or a short board on them, like a KED, something like that. If they tell me that they're hurting anywhere from L1 on down, anywhere in their lower back, down to their hips, their legs, or any of that stuff, they're getting a longboard. It just is, it's a judgment call. But the longboard, what it actually does, yeah, a lot of people are. Anybody that's been in it for a while is used to a longboard on everybody. But very few of your patients are ever actually going to need the longboard. So like lately we've used it more just to move patients around, to slide them out of a car, or help get them up a hill or something like that. We haven't actually used it to transport somebody. Assess for signs and symptoms of a head or spine injury. Begin by asking your patient the following questions. What happened? Where does it hurt? Get your OPQ-RST. But try to get a background on this. This is going to be all on the S portion of your sample. If you're at this point, so you can consider the S to be story. You're just getting background on this information. Where does it hurt? Does your neck or your back hurt? Does it hurt in your lower back? And these are all the answers that are going to make you determine which kind of board you're going to want to use. Does your neck or back hurt? Can you move your hands and feet? Did you hit your head? If they have confused or slurred speech, repetitive questioning, or amnesia in responsive patients, this is a good indication of a head injury. In settings of trauma, assume your patient has a head injury until your assessment proves otherwise. And usually your assessment's not going to prove otherwise. It's just better safe than sorry. The only real definitive way to know they don't have a head injury is an MRI and an X-ray, which neither of which can we do in the field. A decreased blood glucose level can mimic a lot of the symptoms. So get a glucose check if they have an altered level of consciousness, whether it's medical or trauma. If they have an altered LOC, get a glucose. Even if it's, like, holy crap, dude, you were in a bad car wreck, and yes, you have to deal with those things, but don't let the tunnel vision take that away from you, because it could be that they got in a car wreck because they were hypoglycemic. Now you've got two issues. If the patient is found unresponsive, emergency responders, family members, or bystanders may have helpful information. If they're unresponsive, definitely assume they have a spinal injury, so they get the works. If they're unconscious, they get the C collar. Probably going to want to put them on a board, just because we don't know. We don't know if they've got lower back injuries or not. They're not awake to tell us. For your ABCs, if they're trauma, use the jaw thrust. If it's not trauma, you can do your head tilt, chin lift. Make sure you have your suction on you, because you need to keep their airway clear. When we're dealing with trauma patients, at this point in the game and the primary assessment, go ahead and give them the 15 liters emergency oxygen. That's okay. You can always step it down when you get to your secondary assessment if you figure out that they don't need it. I don't like that it says pulse ox value should be maintained above 90, because at this point you're not getting vitals. But yes, when you get that number, keep it above 90. You may find that trauma patients, because of blood loss, it's not as easy to keep them in that 94 to 99, what a normal person would be. That's why they lower the minimum. So in trauma, it can be a little bit lower, but you never want to get below 90. Hyperventilation should be reserved for specific conditions. Usually we use that to slow the bleed. If we have a patient that we think is having a brain hemorrhage or a cerebral hemorrhage, we'll hyperventilate them, because the more CO2 we blow off of them, the more their vessels constrict down, and it slows the bleed. But this is where I say get a paramedic out there, because they need to see the number that their end tidal is at. Because if you go too far, you completely shut off blood flow to the brain, and then we cause a stroke, and we don't want to do that. The hyperventilation is kind of riding that line, and you need to have everything at your disposal for that. So if you're going to go that route, then I'm glad, I want you to know about it, but definitely get a paramedic on scene to make sure that you're doing the right quality of it. A pulse that's too low in the setting of a head injury can indicate a serious condition in your patient. Remember, like I said, as that pressure builds, the pulse is going to slow down, and it's going to start hitting harder with every beat, trying to push blood in. If the pulse is present and adequate, you can continue to evaluate your patient further. If it's not, then do CPR. All right, and then for your manner of transport, if you suspect a head injury, they're going to be an unstable critical patient. If you can get a helicopter out there, then fantastic. That makes it easy. Go for the helicopter. If you can't, still try to get them to the hospital as quick as you can. Make sure you give them good oxygen. Keep an eye on their vital signs. That's going to be very critical, because if they do have a head injury, as it progresses, you're going to see it in the vital signs, especially if they're unconscious. Keep your suction available and maintain the mobilization of the spine, at least the C-spine. If you decided not to put them on a spine board, that's okay. Your history taking is going to be the same. Investigate the chief complaint. If they're unconscious, the chief complaint is what you pretty much determine it to be. If it's a car wreck and they're unconscious, well, that's your chief complaint. Keep in mind the possibility of a head injury when you're dealing with trauma, and don't rule it out if it's medical. Somebody still could have fell and hit their head. Even if you find them in a seated position, doesn't mean they didn't hit the ground and then get up, get in the chair, and then start to have their symptoms kind of onset from there. If they're awake, get your OPQ-RST. If they're not awake, then you can throw that out the window because nobody else can tell you any of those answers. And then get your sample from whoever you can, if not the patient. For your secondary assessment, the way that they divide this up, I still disagree with it, but head to toe. All right, before you go to move your patient, go at least head to knee. So what I'll do is I'll start at the head and I'll be working my way down. When I get to the knee, if I don't find anything wrong with the legs at this point, I'll just stop there. If I see a problem at the knee, then I will feel for a pulse at the foot. If I've got it, great. If not, as an EMT, I'll just note it, whatever. Just need to know that I don't have a pulse there. And the reason being is because at this point in your assessment, you're still fighting time, right? You haven't gotten them in the truck yet. You're not going to get them in the truck until you do your head to toe, because you need to know how you need to roll them, what injuries you need to watch out for while you're trying to get them onto the stretcher. So time's not on your side. You're not going down the road yet. Be quick with this. If you make it to the knee and you don't see anything wrong, then you can even in an evaluation say, all right, because I'm at the knee and there's nothing wrong, I'm not going to worry about the foot right now. I'll get that on my next pass when we get in the truck. And you'll be fine for that. So once you get through your head to toe with them being supine, figure out what side you want to roll them on, roll them over, check their back, put a board under them if you need it. If not, a scoop stretcher or whatever it is you're going to use to put them on the litter, get them in the truck, and then start heading to the hospital. You'll get your vital signs, and I'm going to try to do an actual vital signs class for you guys at the boot camp. I didn't build it into the schedule here, so I'm not going to torture you with it over the internet, but when we actually do the boot camps, I'm going to give you guys a vital signs class, and I'm going to talk about how different injuries will change your vital signs. Thank God. Wait, thank God for not getting it over the internet, or thank God for doing it at boot camp? Okay, good. Yeah, no, there's a lot of stuff. There's a lot of stuff you can glean from vital signs. I don't want you guys to think of them as just numbers, because they're kind of, that's a bad way to look at it. But I'll teach you what I know. It'll be an unofficial class. We'll knock it out. I'll just show you some things that I've picked up, some things that I've learned over the years. And when you're dealing with patients and you see their vital signs, you're like, huh, that's high. No, I mean, it's one thing to know it's out of range, but it's another thing to know what that means. And it can really affect your patient care and the outcome of your patient if you get ahead of things because you saw it in the vital signs first. All right. A decreased level of consciousness is the most reliable sign of a head injury. Again, the brain's the first thing to pipe up when something's wrong, and so they're going to get anxious. Then they're going to start to lose consciousness. Then they're going to be completely unconscious, and if it doesn't get fixed, they're never going to wake up. Look for leaking blood or CSF, especially around things like the nose, the ears. Sometimes you may see it in the mouth, but because the cribriform plate sits up higher than the nasal cavity, if it's in the mouth, you would have seen it in the nose as well. Assess pupil size and reaction, and don't probe open scalp lacerations with your gloved finger. Just because they have a hole in the skull doesn't mean we need to put our fingers in there. It's funny that they have to put that in the lectures. For your neurologic exam, perform a baseline assessment using the GCS, the Glasgow Coma Scale. So I know we've talked about it, and we really haven't hit too hard on it, But your Glasgow Coma scale is a scale from 3 to 15, not 0, not 1, not 2. You get 1 point for each of the categories. A rock gets a 3. A dead body gets a 3. Me, you guys here in the class, y'all are at 15. You're awake, you're conscious, you know where you are. You respond to commands, all that stuff. You're a 15. And the numbers get kind of, I mean, it's a pretty significant drop when you're coming down those numbers. Anything 13 and under is considered high priority for transport. And you're going to see it. If a patient's only got 13 for a GCS, that means they're borderline unconscious. If they're under 8, they're completely unconscious, and the paramedic's going to want to put a tube down their throat. If they're at a 3, you're doing CPR or you're calling a coroner, depending. There's nothing there. Always use simple, easily understood terms when reporting the level of consciousness. We don't use 10 codes. You can use your AFPU when you give consciousness. You can use the GCS if you want to. One of the things that I would recommend is if there's a bunch of you on scene, whoever gets the first GCS number needs to be the one to calculate it every time. Because somebody might be like, I'm gonna give a point for that, whereas somebody else be like, no, I don't. That doesn't count. Let's see. Record levels of consciousness that fluctuate or deteriorate. Okay, yeah, that was the last thing on this slide. Good. This is your Glasgow Coma scale. So as you can see, there is no zeros. Everything, the lowest is 1. So you get 3 for showing up. And then as you look at this, it's a 4, 5, and 6. Each category goes up by 1 to make your total of 15. If there's potential for a spine injury, examine the spine. You're just going to run your fingers down the length, checking for that step off to make sure everything's in place. Inspect for decap BTLS. You should really do that on all the body parts, not just your spine. But check your extremities for circulation, motor, and sensory problems. You should be able to feel the pulse. They should be able to feel you, and they should be able to move their extremities pretty decently. If there's any problems with that, then note what it is and be specific. Pain or tenderness when you palpate the spinal area is a warning sign that a spinal injury may exist, and if it's depending on where it's at, you may have to grab the longboard. That's okay. Just remember, we're no longer using a longboard for every patient. As long as you don't go into it with that mindset, you're okay. For your reassessment, it's just like every other one. If they're unstable, they're going to be every 5 minutes. If they're stable, they're every 15. Recheck your vital signs, recheck any interventions you did in the primary, and try to see if they're hopefully not getting any worse. Multiple interventions may be necessary in patients with head and spinal injuries. If something is not working, try something else. The worst thing you can do is recognize something and not do anything about it. But also know that some things will happen and there's just nothing you can do about it. So if somebody's blood pressure, for example, is over 220 systolic, can we really do anything to bring that down? Is there any maneuver that you can do to a patient that lowers their blood pressure?
Not really.
No, not really. There's a couple of things that we can intervene on. There's a lot of things that we can't. So that's where it's important just to know based on your interventions and know what your protocols are. Look for the things you can fix and fix them, and then everything else just note it. All right. So not everything. Even when we do your evaluations and your not even just your evaluations, but your practice at the boot camp, I'll give you all kinds of things that you're going to detect and you're going to see on your patient. That doesn't mean you have to do something with all of them. Some of them will be way out of your scope. Some of them will be something that I'm just telling you to flesh out the scene and see if you get hung up around it or whatever. So if it's something you can fix, then fix it. If it's not, then you say, all right, cool, I'm going to note that in my report and move on. Compare your baseline vital signs with repeated vitals. Hopefully they trend better or at least stay the same. But if they're continuing to get worse, then um, drive faster. Watch carefully for changes in the pulse, blood pressure, and respirations. The big thing I want to point out about your blood pressure, and again, we'll talk about this when we do the vital signs class, but your normal pulse range, I'm sorry, your normal blood pressure range is going to typically it's going to rise and fall together. So if your systolic rises, your diastolic should rise with it. If your diastolic falls, your systolic should fall with it. If one's going up and one's going down, that's a problem. And if they're starting to meet in the middle, that's a problem. We'll go over that more, but that's kind of what I was getting at. When you're looking at your vital signs, don't just write the numbers down and be like, I don't know what it means, but I'm just going to write this down. Take a look and see. And as you do learn this more, you're going to look at it and be like, oh crap, all right, I know why that's happening. And either you or you can point it out to your paramedic and be like, hey, this guy needs this and I can't do it, but you can, that kind of thing. Because your paramedic is going to be just as busy as you are with all the stuff that he's got to do. Sometimes you may be able to help point him out to something that's important that he needs to prioritize over whatever it is that he's, whatever protocols he's running through in his head, that kind of thing. All right. Let's take another. We'll start our next break a little early, just because it's already 5 minutes till. So be back at 5 minutes after, and we'll finish up for the night. All right, guys, time for the home stretch. We've got a couple more sections to go over and we'll be done for the night. So emergency medical care of head injuries. 3 general principles are designed to protect and maintain the critical functions of the central nervous system. First of all, you need the airway, right? Can't breathe, can't get oxygen to the brain if they can't get their airway open. So if necessary, begin and maintain ventilation and always provide high flow supplemental oxygen. If you feel like they have any kind of impairment for any reason, be it blood loss or increased ICP, any of these sorts of things, is going to be very important that we give them as much oxygen as we can, even though I know we try not to say don't over oxygenate your patients. What they're normally going to get may not make it to the brain. So we try to give them a little bit more. That way, what does get there is got good oxygen. Control bleeding and provide adequate circulation to maintain cerebral perfusion. So if you need to, begin CPR. Be sure you follow your standard precautions and assess the patient's baseline level of consciousness and continuously monitor it. Your patients may go in and out. Well, they may go in and out, but they're also going to, as things get worse, they're going to start to degrade. And if that's happening, we want to catch it sooner rather than later. So this is one of those times where that whole every 5 minutes, every 5-minute reassessment may still be too long. If you've got the opportunity to check it more often, then check it more often. Manage their airway, like we were saying. So the most important step is making sure you have A. If you don't have A, you won't get B. And if you can't get B, you're going to lose C. If the patient has an airway obstruction, perform the jaw thrust maneuver. If they're worried about a neck injury, we really don't want to do a head tilt chin lift. But if that's all you can do, if there's just no other way to get it, take your chances, life over limb. If the patient hasn't, well, I already said that. Once the airway is open, maintain the head and cervical spine in a neutral inline position until you have placed a C-collar. And you have secured the patient on a backboard or whatever it is you're going to put them on. That's why I was saying, just because you put the C-collar on somebody doesn't mean your partner can let go of the head. Still maintain that manual C-spine until they are completely packaged. Then you can let go. Remove any foreign bodies, secretions from the airway, so you're going to need to suction. Once you've cleared the airway, check for ventilation. Make sure they're able to breathe. If they're not breathing adequately on their own, then you're going to have to do the breaths for them. Oh, wrong way. For circulation, if the heart's not beating, you're going to have to do it, which means CPR. So just like any other call, regardless of the fact that it's a head injury, if they're missing either A, B, or C, you have to give it to them. All right, if they don't have an airway, you make an airway. That's easy. If they don't have a pulse, that means you're going to be giving chest compressions. That is all CPR really is. Active blood loss aggregates hypoxia by reducing the available number of oxygen-carrying red cells. Is that on? Okay, yeah, it's kind of on the slide. That's another reason why we will over-oxygenate sometimes in these cases, is because there's not a lot of red blood cells making it where it needs to go. So we want to make sure that every red blood cell gets oxygen. You can almost always control bleeding from a scalp laceration by applying direct pressure over the wound, but be careful if there's a skull break there. Let me get to the right slide. If there's a skull break there or something of that sort, you don't want to press so hard that you start pressing into the brain cavity. If the dressing becomes soaked, we do the same thing we do with anything else. We just put more on it, right? Just like that Simpsons episode where the dog was paper trained, but Homer didn't want to replace the paper, so he just kept throwing more newspaper on top of it. In our line of work, that actually is the right answer. So if your patient wets the pad, you just put another pad on it. Shock is usually the result of hypovolemia in these cases where they've bled out. If this is the case, if you're going into shock, just like any other shock, that tells you that the situation is critical and they need to go to the nearest trauma center as soon as possible. All right, for Cushing's triad, we mentioned it earlier. They really didn't touch too much on it. This is what you're going to see your vital signs doing. Remember, as the pressure in the skull increases, the brain is saying we need more blood, we need more oxygen, we need more nutrients to survive. So they're going to send a signal. It's going to send a signal to the heart that says beat harder. Your blood's not getting to us. So your heart's going to beat harder, but the way it's going to slow down at the same time. So you're going to see their pulse rate drop. You're going to see the blood pressure increase. And the irregular respirations is happening because the body assumes that if it's not getting good blood flow to get oxygen to the brain, then it's not going to have that same good blood flow is not there to get waste away from the brain. So the body's going to try harder to blow off the CO2. And it may be that the only place in the body that's getting any extra CO2 is the brain, which means that the brain doesn't realize that the rest of the body is fine. So as it's trying to blow off all that extra CO2, it's actually bringing their CO2 too far down, which is one of the problems that we run into. So the Cheyne-Stokes breathing is there for a reason, but the brain may be mistaken on when to use it. Again, these are traumatic injuries. The brain may be making the wrong decisions, and that's sometimes it's the case with this. Perform controlled hyperventilation if your patient via positive pressure vent. So you're going to use a BVM at a rate of 20 breaths a minute. If they're bleeding into the brain cavity, this will constrict the blood vessels and slow down the bleed. It doesn't fix them, but it buys you some time while you're trying to get them to a hospital. All right. Remember to follow your standard precautions when you're taking care of spinal injuries. As always, maintain the patient's airway while keeping the spine in the proper position. Assess respirations and give supplemental oxygen. So perform your jaw thrust to open the airway. When it comes to your scenarios and everything for the class, I'll go ahead and tell you, if it's a trauma patient, I'm not going to tell you that you can't do the jaw thrust. I want you to be able to do the jaw thrust. So that's your answer for that. In the real world, yes, you may come across a patient that doing that just doesn't open their airway. In which case, you do what you have to do. But that's not something that we're going to throw at you in the class. So don't worry about that. That's not going to be an assessment. That's not going to be anything you will get from us or your evaluators at the registry. After you open the airway, consider inserting an OPA. If they take it, fantastic. If they don't, switch to the NPA. Just remember to be careful that you don't push through the cribriform plate. Have a suctioning unit available and provide oxygen. So that's a picture of your jaw thrust. Immobilization of the cervical spine. Establishing and maintaining the airway is your first priority. So if you're stuck between do I do C-spine or airway, do airway. Once you're done with that, and you know that those life functions are there, then you can start to worry about the C-spine. Immobilize the head and trunk so that bone fragments don't cause any further damage. That's where you're taking that manual stabilization. And let's look at this picture. If you or your partner is doing a jaw thrust, you're at the same time doing the manual stabilization. Your hands are there. So if you have to put somebody on the airway to say do a jaw thrust, just tell them, I need an airway, do a jaw thrust, and maintain their C-spine for me, because they're already going to be doing that. Immobilize the patient in his or her current position, unless it's something stupid like they're prone. All right, you're not going to immobilize somebody face down; they're not going to be able to breathe. You need to be able to get your patient into a supine position. What they're really referring to here is you're not so concerned about their legs and their arms. That can stay like it is, whatever. That's fine. Don't waste time trying to make them nice, neat, and pretty before you immobilize your patient. Go ahead and immobilize them, but make sure they're face up. Just be common sense on that one. They need to be able to breathe, and you being the responder need to be able to do your assessment. You can't do that when they're face down. Cervical collars provide preliminary partial support. You can still move your head. That's why even though you put this on there, you should still have somebody holding. They should be applied to every patient who has a possible spinal injury based on the MOI, their history, or their signs and symptoms. Cervical collars do not fully immobilize the cervical spine. Therefore, you must maintain. I'm glad they put that there. I used to have to just say that as above and beyond, but there it is now. You do still have to maintain manual support until the patient has been completely secured to a long or short board. To be effective, they need to be the right size. We'll show you how to size those at the boot camp. Most of the time, you're going to use either a standard no neck, or they call them necklace C-collars. This is what you're looking at there. Some of them are adjustable. Some of them are just pre-made. Like a lot of the ones, if I'm not mistaken, unless, correct me if I'm wrong, Wesley, but you guys use preset, pre-sized C-collars. And the easiest way to tell the difference is in the color of the Velcro strip. The red ones are your normal ones that you're going to grab, and then you have the green ones, yellow ones as different sizes. Okay, yeah. Stabilization will be strapping them with the head blocks or down to the board. Correct. That's the point where you can take your hands off their head. The C-collar is not enough. You still need to hold their C-spine even with the collar. But once they're secured to whatever device you're going to put them on, be it a board or something like that, then you can remove your hands. Yeah, I think those are the most common ones now. They're the easiest because you can stack them all in there, and then you just say grab the red one, or something like that, and they'll go get it. Yeah, yeah. If they're posturing, good luck. That's like trying to stabilize in the middle of a seizure. It's almost impossible. All right. So anyway, the cervical collar should rest on the shoulder girdle and provide firm support. There shouldn't be any real room for the head to tilt up and down. It should be from the center of their chest up to their chin, and it should be able to hold it that way. There's still a little bit of room for movement, but you'll find that if the C collar is in place, it's that forward and back motion that you're really restricting. You feel bad strapping them into the collar or to something like the stretcher? Yeah, but if they're posturing, dude, I mean, don't feel bad, because if you don't, they're not going to make it. In fact, they got a low chance of making it even then. But yeah, no, it does feel weird. That's one of those things that it's like it sucks, and you may need to talk to somebody about with it afterward, but it's got to be done. All right, prep for transport. Supine is the easiest because you don't have to really do any extra motion, but immobilize a supine patient by securing the patient to a long board and then or a vacuum mattress if they need it. You can use the long board to move them if you're not using it. If it's actually part of your stabilization intervention, then you can't take the board off. The doctor has to take it off at the ER. If you're using it just to maneuver your patient to the stretcher, and that's the reason you're using it, then yes, you can remove the board. You can use a 4-person log roll. You can use a scoop stretcher. Any of those will work. For a vacuum mattress, this is an alternative to the long board. These are molded to fit specific contours of the patient's body, so a lot of the downsides of the long board are fixed with this. If your ambulance carries these, then great, but I don't know of any ambulance company that does, because they're expensive and they break easy, or they pop, that kind of thing. But these also provide thermal insulation, so it's fantastic if you're dealing with somebody who's been down on the ground or in a house and it's cold. Even down there, you can have hypothermic injuries for elderly that fall in their house and they don't have any heat, or whatever. They're laying on a cold tile floor. The tile floor will take their heat away. These are excellent for elderly patients, but the drawback is its thickness. So you only got so much room in the back of the truck. You wrap a patient in one of these things, it's going to take up a lot of space. It cannot be used for patients who weigh more than 350 pounds. And these can be used on supine, sitting, or standing patient. And they will not fit in a chopper. That's good to know. All right, for sitting patients, some patients with a possible spinal injury will be in a sitting position, such as a vehicle crash, asleep. Use a short backboard or a short spine board extrication device to restrict movement of the cervical and thoracic spine. You guys are going to go over the KED when we go to the boot camps. So that's a seated spinal immobilization device. It only works from the waist up. It doesn't do anything for your legs, which is fine because that's not really what you're concerned about with a seated patient anyway. KEDs are fantastic for children as well. They're even brightly colored, so it's catchy to a kid. The kid won't be so afraid of it because it looks like a toy. So if you use a short board, you can actually take them out of the vehicle with this and then secure the long board if you need to, but you don't necessarily have to. The exception to the rule are situations in which you don't have time to first secure the patient to the short board. So if you or your patient's in danger, if you need to gain immediate access to other patients' injuries, justify urgent removal, those kind of things are situations where you won't bother going with the whole short board then to the long board thing. All right, for standing patients, immobilize the patient to a long board before proceeding with the assessment. So if they're standing up, you just make them continue to stand. Have somebody holding their C-spine, talking to them, letting them know what's going on. Have another patient, or I'm sorry, have another EMT or first responder, any level can do it. Have two people put a long board up behind them, and then just have them just let your patient know so they don't freak out. Be like, all right, we're going to do a trust fall here. It's going to feel like you're falling, but we've got you. You're going to be laying on this board, and you just lower them to the ground, and then you can do your assessment. Anytime you do any kind of move like this, that's a group move, because this is not something that one EMT can do. You need a couple people for this. Whoever's at the head is the one that's in charge. It doesn't matter if they've been in the service for 20 years or if it's their first day. They're the ones that are saying what to do. If you don't want that guy in charge, don't put him at the head. During the assessment, pain in the spine may be missed because of shock or because the patient's attention is directed to more painful injuries, right? So if you've got pain in your spine and, oh, by the way, you completely mangled your left leg, the left leg is probably going to pull your attention as a patient and as an EMT. You'll be looking at that going, dude, that looks gnarly. And both of you may miss the fact that he has a step off or something in his spine. So be aware of that. And if you think you're going to need to, sorry, it's been a long day. If you think they're going to need any kind of spinal immobilization device, then use it. But don't just jump straight to the long board like we used to be taught to do. That's just not where we're there, not where we're at anymore. So this is a KED. This is what I was talking about. I said it looks like it's bright colored, looks like a toy. Kids actually like it. They like to play with it. You can use this as a short board. You can use this for pediatrics. It's really nice, and we'll work on how to apply these when we get to boot camp. These are your long boards, scum of the earth, horrible things, worst things ever created, at least, until we find out we need to use them more, and then they're going to come back and be the golden children again. But these are the things we don't really use that often anymore. You really do have to have a really bad lower back spine injury or hip injury, something of that sort, to really consider using the long boards these days. Helmet removal, and that's going to be it. This is the last thing for the night. As you plan your care of a patient wearing a helmet, ask yourself the following question. Is the patient's airway clear? Is the patient's breathing adequate? Can I access his airway and breathing, like doing for his giving oxygen or bagging him or something like that? If you can access it, then the helmet can stay. The helmet typically only has to come off if it hinders your ability to treat the patient. So if you can if it gets in the way of the C collar, you can take it off. If it gets in the way of you doing your A and B for your primary, you can take it off. That's okay. A lot of helmets, motorcycle helmets, stuff like that, the front face actually lifts off of it. I want to say that they're making football helmets to do the same thing now. I'm not entirely sure, but that's one of our previous classes we were talking about that. So that's something to consider, where it makes it easier to, a full frontal, full face helmet. You can still reach your patient. A helmet that fits well prevents the patient's head from moving and should be left on unless it hinders your assessment. So you can remove the helmet if it's a full face helmet and it doesn't have the removable piece. It makes assessing or managing the airway problems difficult, and removal of a face guard to improve airway access is not possible. If it prevents you from properly immobilizing the spine, if it allows excessive head movement, say it doesn't really fit them properly, it's too big, or if the patient's in cardiac arrest, take the helmet off. Okay, so there we go. That's a new one. Bull riding helmets, face shields rotate up. The preferred method for removing a helmet should always be at least a 2-person job. So you're going to have one person maintaining C-spine while the other one pulls the helmet off. Technique for helmet removal depends on the helmet type, and you and your partner should not move at the same time. So one will hold the head and then stop moving while the other one goes to remove the helmet. Consult with med control first if you ever have any doubt. And then for your alternate method, the advantage of this method is that it allows the helmet to be removed with the application of less force, thereby reducing the likelihood of motion occurring in the neck. The disadvantage is that it's slightly more time consuming. So you'll remove the chin strap, remove the face piece, pop the jaw pads out of place with a tongue depressor, place your fingers inside the helmet during removal of the helmet. The person at the side of the patient controls the head by holding the jaw with one hand and you're basically going to hold the back of the head and the jaw. Insert the padding behind the occiput, which is the back of your head. And then you're just going to remove the helmet, make sure that the head and neck don't move. And that's it. Is there any questions tonight? Like I said, I don't expect anybody to be a master of TBIs. There are entire classes on this stuff. And even then, we really don't know, even ourselves as practicing professionals, we really don't have all the answers when it comes to TBIs. We can only tell you what we know so far, especially when you start getting into some longer term things that come from them. Some of the long term effects of TBIs and stuff like that, we're still learning that kind of stuff. It's kind of up there with PTSD. It's like we know a lot, but the more we learn, the more we realize we really don't know that much at all. But anything that we talked about tonight coming across as Greek to anybody? Is it pretty solid? Do y'all feel good about it? All right. Your pin for the night is going to be BC Bravo Charlie 28. T is in trauma. Yeah. Yeah, you really do run into this on almost all of your trauma calls. So the big thing, and we're going to cover a couple extra things at the boot camp to kind of bridge the gap between this lecture or this training and what your PHTLS training will be. So we're going to teach you a little bit more. We're going to get more into the posturing and stuff like that. But this is the bulk of it. For a basic, this is no matter what class you go to, this is pretty much what they're going to teach you. They may add a little bit more to it, but this is it. Yeah. Yeah. Well, hey, we only got like 1 or 2 more chapters, I think, for trauma. That's why we've been repeating it. We're almost done with the module. I did send out some emails today just to kind of catch you guys up. I'm getting more critical about your test deadlines because we're reaching the end of the class. Before long, just a few weeks from now, we're going to be at the boot camp, and I need everybody to be completely done with all of their tests by the time you get to the boot camp. So some of you are ahead. Some of you are right where you need to be. Some of you are just a little behind, and some people are like on chapter 5, which I'm working with that. Anyway, yeah, if catch up, keep up. It's all right if you're a little bit behind. I'm not worried about it. Some of you have reached out to. No sweat, as long as you can catch up. But if there's no other questions for the night, then we'll call it. And I'm going to celebrate what's left of my birthday. Y'all have a great one.